Welcome to today's meeting of the Health and Social Care Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners and adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chairman of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure that your mobile phones are on silent. We are not expecting a fire drill, but if the fire alarm does go off, please follow Nikki to wherever she goes. As chairman, I will call on those to speak during the meeting. If you are speaking, can you put your microphone off? If you're not speaking, obviously switch it off or on. I can't remember what I said, but I think you get the gist there. Ultimately, it's for those on the YouTube channel to hear, because I know we can all hear each other in the room, but the microphone helps those who are watching on the YouTube channel to hear us. Okay, excellent. So I'm going to move on to the agenda. Nikki, do we have any apologies for absence?
Chairman, we've had apologies from Councillor Chapman.
Okay. Thank you. Are there any declarations of interest before this meeting? No? Fantastic. Everything that we're going to discuss is going to be discussed in public, am I right? Yes, excellent. So the first agenda item was to be the Mount Vernon Cancer Centre Strategic Review Update. Unfortunately, Jessamy is not feeling well, so she's asked if she can deliver the update to us in our January meeting, so obviously I've said that's okay. So agenda item 4 is going to be rescheduled for our January meeting, which means we're going to start with agenda item 5, which is a health update from Central and North West London NHS Foundation Trust. And we have Vanessa here. Take it away, Vanessa.
Thank you, Chair. So I'm Vanessa Odlin. I'm Managing Director in Central and North West London, and I'm responsible for the services that we deliver in Hillingdon. And they comprise, for people who don't know, they comprise of both mental health and physical health community services. We also have mental health inpatient services for adults in Hillingdon, and a ward for older adults who are suffering with mental health challenges. So my update today is a very kind of brief update, just to give you some context. I'm going to try and use the clicker properly. Do I just press the button? Oh, no, it wasn't on, thank you. It's all right, there we go. So if I start with the Children's Mental Health Update, and I think the last time that I was here talking about the update, or that you had an update from Central and North West London, was sharing the challenges that we had in terms of the waiting lists in our children's mental health services. I believe since I've been here, you've heard from our service director for CAMS, Tina Swain, and she hopefully described in detail the work that we put in. So in essence, we have expanded the workforce. We've really focused on initiatives and innovations to support bringing down the waiting list, and I'm really pleased to say that the waiting list for both assessment and treatment has dramatically reduced. We can't take our foot off the pedal because we know that we have increased referrals coming through. We know that both the pandemic and actually children are suffering more, so we know that we need to think much more creatively about both preventative support to put in, but also support for when they need both assessment and treatment. So hopefully you see here from the graph, I mean, the graphs speak for themselves in the presentation, that they are coming down. One of the new initiatives that we're very excited about is the new model for children who are 0 to 5 years old, and that's very much seen as a preventative measure and trying to reach young people before they get to a point of crisis and in their early years. And that's enhanced by the mental health support teams that we have going into the schools, so that also the schools feel supported to look after children who are maybe struggling with their mental health. Moving on to our adult mental health update, I'm really pleased to say that we launched our the Hillingdon retreat, so our crisis house in Hillingdon. So that we had a soft launch in the summer, in August, and we formally opened last month the retreat, and we've seen a number of people use the retreat, and it's really, sorry, I've not clicked that. There we go. And it's really supported a number of people who are in crisis, and we will be piloting that over the next 12 months, and we are doing some touch point reviews just to see how it's being used by people, and again, if there's anything we need to do to change the criteria or access for the retreat. It's actually run by an organisation called Comfort Care, but very much in collaboration with Central and North West London and also the local authority, because we see this very much as a partnership, and actually for it to be used appropriately we need to be doing that as a partnership. Other things that we're really focusing on in terms of our adult mental health are the ARS roles, so that stands for Additional Roles Reimbursement Scheme. So these are clinicians who are working in primary care, who specialise in supporting people with mental health, but again supporting our GPs in primary care who may be seeing people who are struggling with their mental health and maybe don't need to be referred to a community mental health team, but may need some extra support. So they've been in post for a number of months, and that's we're being told by primary care is very helpful. And then finally, under our adult mental health update, and very much links to the work we're doing around children's mental health, is we've set up a service for young people or young adults who are between 16 and 25. So we have a pathway lead in place. And we have a number of initiatives and pilot schemes that we're putting in place to support young people who are going through that transition stage, because we've heard from young people that that's a particularly difficult time for them anyway in life, and if you're having to transition from one team to another team, that's very difficult. And we're very much linking in with both the university and voluntary sector organisations to run that. So if I move on to our physical health community services, some highlights. So we're doing far more than you see on one slide, but really wanted to focus on things you probably haven't heard about yet. So obviously, what isn't on the slide is the work that we're doing with the Hillingdon Hospital around supporting discharge, and we know that obviously at this time of year that's a huge focus for us in Hillingdon, and making sure if people don't need to be in the Hillingdon Hospital that we're supporting them with their discharge, and we're very much in Central and North West London committed to that, and we have seen in North West London data that actually Hillingdon Hospital do very well on discharges, and we definitely believe that is part of the partnership working. If I kind of stay on the adult theme around physical health updates, we are an early implementer site for our national lower limb wound care strategy, and that's been actually we've been innovating in that area for a long period of time. In a practical sense, actually the teams are going out and advertising and talking to people about how they can kind of recognise how they can support themselves and how they can access services when it comes to wound care. We are also, with regards to our children's services, we've been working with the local authority on our family hubs. So that's really driven forward. We've also set up a really good website. So for people who want to or for families who want some more support, rather than having to access any statutory services, we've got a really easy to use website where they can get self-help and support from, and we've been doing that in conjunction with the local authority. And finally, our ARCH service, so our Addictions Recovery Community Hillingdon service has been successful in receiving funding. They have been driving forward with their day programme, and they have been focusing on their assessments. The other thing that the ARCH service has been doing is supporting the mental health service at Riverside, so the inpatient service at Riverside, to ensure that where service users have maybe a dual diagnosis of mental health and maybe addiction, that they are supporting them on their discharge journey, so really focusing on discharging them out of hospital. So I think that's a bit of a whistle-stop tour in terms of the services that are covered by Central and North West London, and open to any questions.
Thanks, Vanessa. Yes, obviously last week, my life flashes before my mind, but at our last meeting we had obviously all the external health providers, and unfortunately you guys weren't able to attend that one. That's fine, because obviously you're able to attend here, so it's good to have your sort of update. I've got a couple of questions. Firstly, on the children's mental health update, when you talk about the new model for 0 to 5 population, which sounds really, really interesting, because obviously earlier is always better. How do you identify who needs support, and how do you provide that support?
So we have we've currently got a small team of clinicians who are running that service. So identified either through GP, so it would be through the kind of referral route that you would see for CAMHS, and they work very closely. So it's a kind of subset of the CAMHS service. So they work very closely, and will kind of sift out any of the referrals that come through there, but also link into primary care. And how they I mean, I can't speak in detail about in terms of kind of treatment, but in terms of how they link in with families, is they very much look at the whole family. So they're not just looking at the young child, they're looking at the whole family to see what support they can provide to the whole family, and what kind of steps the families can be putting in place. It's early days at the moment with that approach. If we see kind of success, it may be something that we grow.
Obviously, especially when it comes to children's mental health, early intervention and good intervention at the earliest possible moment is very, very important to stop things developing. I mean, is this the kind of approach you're taking to the 0 to 5 population? Is it something you could think about expanding further up? Because let's say if somebody's 10, for example, they still probably need that same quick, focused and family-based care.
So the mental health in schools teams are the team that we're trying to get to very much do that. So picking people up, or picking young people up much earlier. So that's where we see. But obviously the 0 to 5 young people wouldn't necessarily be in school yet. So what we're trying to do is have preventative from that kind of whole range. I guess I would finally say, obviously I've talked very much about the physical health 0 to 19 service and the website. What we want to do, and the work that we've been doing with the local authority for young people in the community physical health services, we want to very much try and think about the child as a kind of, or this is a holistic service. So how do we kind of link some of the stuff we're doing together?
Excellent. And one last question from me. So obviously you came to our May meeting to talk with the police about managing issues to do with those who present themselves with mental health issues at hospitals and the turnaround, all of that sort of stuff. I know we asked for a sort of update in January, and so you can't answer too much about it now. But as you're here with us, is there any sort of update you can give us right now on where we're at with the improvements that we can make in that area?
So yes, so when we came in May, we committed to, and I think we'd already absolutely started on working together much more collaboratively with the police. Since then, we have had regular meetings, so both regular senior meetings with the police to identify much more the kind of strategic work that we need to be doing together, but also having a space where we do case summaries, so maybe where the mental health team may have some cases they want to discuss with the police, and the police may have some cases they want to discuss, and much more that kind of working together. We have also had, we committed to doing a crisis care concordat meeting that's chaired by the North West London ICB, so Richard Ellis took that upon himself to chair on behalf of the North West London ICB. So we have had our first crisis care committee that was also joint with West London, and we also had representation from I'm going to have to remember this now, but representation from H for All, because we've got the high intensity user service, and I think there was very much a recognition at that meeting that a lot of people in different organisations, whether they're voluntary sector or statutory or the police, actually have a lot of contact with the same people, and what we want to be able to do is not just think about putting lots of strategy in place. Actually, people want to have an individual care plan, and they want to know what that is, and when they're in crisis, they want to know where to go. And I guess that's where the kind of crisis house, our retreat in Hillingdon, comes in, because actually we've talked to the police about whether that, how they might use that if they're picking people up, and how we might use the Coves Cafe, our crisis cafe, a little bit more, and how the police again feel that they might be able to use that when they see people in crisis. And I very much are kind of coming together and having a plan around coming together. So I do know that we are coming with a proper update for you in January, and we'll be able to hopefully give you some more statistics around that.
Good, yeah, no, that would be appreciated, because it sounds obviously positive, but obviously a bit more detail. I know I like a child who's picked up a present to shake it before it's unwrapped, to ask for a sneaky peek on that, but it is good to find that sort of communication's happening. So I'll open it out to other committee members. Rita, I'll go with Rita first.
Thank you, Chair. Vanessa, adult mental health, something that's quite close to my heart. Well done on the Hillingdon retreats. I've got a few questions on that. Is that something that would be used if Riverside was to possibly, what's the right word I'm looking for without being, it would be a bit too harsh for a patient, but the retreat would be something that they could go into? Yeah, and that's one question. So I'll do all three together, because they'll all link in.
If you can certainly have three questions. If they're related, do them together.
Yes.
If they're on separate matters, then do them individually.
No, it's all to do.
Okay, excellent.
Yeah.
Do all three together. Yeah.
So once you answer that, and then I'd like to know how many patients it would be able to house, the length of the stay that we would determine for each patient, and if it's a success, are there plans to open anything similar in the borough?
Okay, so people can access, so in response to how people, or why would people go to the retreat, and I it's a really good question, and maybe I might get it wrong, but people can access it if at the point of crisis. So there might be, I'm just going to give examples in kind of both ways. I mean, ideally what we're trying to work towards is people not getting into crisis. So I say it's a crisis house, but actually we'd rather people have it as part of their plan of care when they might start to feel like they're getting into crisis, and we're trying to work with obviously patients that we know in the community and trying to get them to go in there before they get to A&E or before they are in true crisis. But people are, up until now, have been really kind of accessing it when they're in crisis, and they don't need an inpatient stay. So this is not. So although it is instead of an inpatient stay, you would have to meet the criteria. We wouldn't be saying, oh, we think you need an inpatient stay, but you can come here instead. If you need an inpatient stay, then that absolutely needs to happen. But yeah, the crisis house is very much a kind of is a non-clinical space. So like I say, it's run by Comfort Care, who are not who are a third sector organisation who run it. So that's kind of how you would access the retreat. The number of people that can be in the retreat is 10. The length of stay in terms of the retreat, we really want people to stay there obviously as less time as possible. I think it's between 7 to 10 days, and I think there is a review at different points of their kind of stay, because a review from their team, so it's overseen by the home treatment team. There is a review at different points as to whether they actually might need to go into hospital or whether they can actually leave earlier, and we'll be doing an evaluation, and we're doing an evaluation very much on the outcomes for people, so and we also want to know from people who are using it where they would have gone instead if they've come in here, where else would they have gone if they've come straight into the retreat. It's very nice, actually.
Gary, you want to come in?
Yes, sorry, I think I might be able to assist with this. There was a more detailed update report on the retreat that went to last week's Health and Wellbeing Board. So if the Council would actually like to go look at the agenda for the last Health and Wellbeing Board meeting, and appended to that report is actually a couple of case studies which will give you a bit more detail, both about the needs of the person when they actually went into the retreat, but also the outcomes from the experience.
I'm going to go June first.
Thank you, Chair. It's just thrown off there. I'm going back to the retreat, Vanessa. Is it Vanessa? You said there's 10 places. If there's 10 places, that's only 10 children, or 10 teenage adults. Is there additional places, and what about those people who actually is needing that retreat or needing that input in crisis? What happens to them? And I hear what you're saying, Gary, about it going to the Health and Wellbeing Board. Is the council looking to see how other those young people who is out of the system or who's unable to access the system, what provision is in place for them?
Okay. Just firstly, it's for the retreat crisis house is open for those 18 and above, so it's very much a kind of adult crisis house. And we haven't actually been, as far as I'm aware, we haven't actually been full yet in the retreat. I think what we would want to do is make sure that we do an evaluation, because Gary can answer as well. If we need more crisis houses and this is as successful as we think it's going to be, then we would have more crisis houses in the borough. And I think that was to your point earlier, actually, your question earlier.
Chairman, just to reinforce what and add to what Vanessa is saying. Basically, I think it's taken us 18 months, 2 years, if not longer, to actually get the retreat, get the crisis recovery house up and running and actually supporting people. And it is a true collaboration between health and care partners, but it is a pilot. It's something that's actually worked in other local authorities and actually Comfort Care Services who are delivering this for us under contract with the council are actually operating similar models in other parts of the country. But we actually need to let the pilot run its course just to see how successful it is, and then once we've actually evaluated it, take it from there, really.
Am I right in thinking that one of the places that has something similar was Northamptonshire, where they opened one which was very successful, they opened a second, but they've been struggling to fill the second one? And so it's one of those things that's a very good idea, but it's about understanding that need that we have at a regular time and getting people to refer and use it as well.
Yeah, no, you're quite right. We need to make, and I think that's why we wanted to do a pilot, actually having this number of spaces or rooms available actually is we think is probably the right number based on the research that we've done across some of the other areas where they do have crisis houses. And I think to your point around how people kind of get referred, what we've done is we don't want there just to be kind of one door, one front door, one door in. We want to make sure that there are a number of access points to get into the crisis house, which is why I kind of related it to the work we're doing around with the police. You can't just be dropped off there because we do need to make sure that's safe, but we also want to make sure that everyone feels that they have full access to it. And like I say, it's not just at the point of a huge crisis. Actually, people are able to access it before they get into crisis.
And that would be linked with the hospitals as well. Would that say? Would it be linked to the hospital where you have the crisis where they were unable to cope with?
Yes. Ideally, you would use. So the idea is that people would be able to use the retreat crisis house before they get into hospital. If people need hospital, what we don't want to do is do it instead of hospital. If people need hospital, they'll need to go to hospital. But if they are either in maybe a health-based place of safety, because they've been in crisis, they might be in A&E, they may be living at home, and they may have been seen by either their home treatment team or their community mental health team, and their care coordinator or their doctor has said, we're a bit worried. We also want to, like I say, open it up to kind of even wider than that, which we're doing now, looking at seeing what other places or what other professional groups we can open up into. And I did mention H for All earlier as well, so our high intensity user service who work with residents in Hillingdon who maybe access the Hillingdon Hospital more than a couple of times. They also are very much on that kind of pathway. They have a kind of referral pathway. The other thing that they're doing actually that I didn't mention is we've put together a video. So a lot of people were saying, oh, I don't want to go because I don't know what it looks like or I don't know what it feels like. So we've put together a video that can be shared out with people. I know that we're putting a lot of a kind of media campaign out across Hillingdon so people are aware of it. The other thing we're doing is for the residents or for the people who are seen by the high intensity user service, some of them are actually going to have a look at it where we can, because we really want to make this feel like something that's accessible and not scary.
Could you share the link with Nikki so she can pass it to us of the video? So that'd be quite interesting. Okay, yeah, one more. Oh, just quickly before you do one more. I mean, this is very interesting. So when you come back in April to do your almost end of year report, maybe a little section on this and how the pilot's going and what you're finding, I think would be of interest to us. June.
Just one more question in regards to access to the website that you raise. What provision are in place for those people who don't have access to the web or any communication regarding to linking on to the digital services that is available?
That's a really good point and one that I'll take back to the team, June. I think that's a very good point and very fair challenge back.
Philip.
Thank you. I've got a couple of observations and a couple of questions, if I may. I can do it all in one hit, if you like, or
yeah, as whatever you think's best. Philip.
Okay,
go for it.
Okay. But my observations are: thank you very much for the presentation. Very useful. I'm seeing this round of updates from health providers as being a bit of a warm-up, if you like, for April, when we'll have a full suite of performance indicators, which will give us a much more of the picture. But certainly it's useful to know what's going on, without a doubt. The presentation is good, although can I just make a plea for us to get these a little bit before the last minute for these meetings? I don't know how long we've had this, but I mean, I'm seeing this for the first time. If it was even a few days ago, my apologies, but I don't think I've seen it. So, just a plea, and that applies to everyone, not just CNWL, by the way. Okay, my questions are these. In relation to the ARCH service and hospital admissions, certainly one of the issues that we've had going back some years, certainly in my time in Cabinet and dealing with health, was the number of alcohol-related hospital admissions in the borough being a little bit above the curve, not quite where we want to be. Can you give me a flavour of where we are in that regard at the moment? And also whether certainly the ARCH service used to have someone at the hospital a lot of the time to make sure that that interaction was happening with individuals and third-party groups, perhaps rough sleepers, for example. I just wonder what that interrelationship looks like now, if you wouldn't mind. So that's my first question. Shall I leave it at that and come back to the second one?
If there are separate matters, then do each matter separately, because I think it's easier to answer. So go with that one first.
Is that clear enough?
It is, yes.
Thank you.
Thank you. And noted on the performance indicators for April's report.
We have said that to everyone, not
That's
just
fine.
yourself.
I don't feel singled out. It's okay.
For scrutiny purposes, really.
Absolutely.
Yeah.
Absolutely. No, that's fine. And when you talk, so in your question, when you talk about hospital, do you mean the mental health inpatient hospital or the Hillingdon hospital, the acute hospital?
I was referring to the acute hospital, actually. Yeah.
So I can't answer, because I would probably, if Hillingdon Hospital were here, I'd ask them to talk about kind of alcohol-related admissions to hospitals. So I would defer to them on the answer for that. But in terms of the support that's provided into the hospital, that is, the Arch absolutely work do work into the hospital. I think it could be more. So the conversations we've been having with the Hillingdon Hospitallers, they would like more support from the addiction services, both in their A&E and in the hospital. I think it's predominantly in the A&E because they try and bring people in, and then they try and move them out very quickly with the support from the addiction services. But yes, you're right. We probably do need to think about how we enhance that.
Okay. I was interested purely because of the relationship with Arch, and perhaps I hadn't made enough of a distinction between different parts of the acute service. But interesting. Thank you for your response. Anyway, my second question was around children's mental health, and again, good to note progress on that. For many years, we talked about the lack of preventative support for children, stopping them. Or stopping many of them needing clinical interventions further down the line at much greater expense. There isn't too much about that here. Am I taking it that we're in a better place all round on that now, or is that something that we're still looking at, or something that you don't know too much about perhaps? I don't know.
Did you mean the preventative side?
Preventative support. So, for example, yes, we've had things like COOT in the past, haven't we? We've had the low-level parochial stuff. We've done work with schools, haven't we? And we were looking to raise awareness in GP practices, weren't we, on this sort of thing. So I just wonder how that sort of, those low-level services, if you like, preventative services, how well developed we now think that is compared to where we were a while ago. Thank you.
No problem. So I would, so they are absolutely, all of those things are embedded. So COOT is still there and is still available, and people are signposted to that. We've also got we recently had some money available for preventative, or certainly for CAMS, and we put it into preventative approach. So the local authority, we gave the local authority some money, and they've done some third sector grant schemes. So enhancing some of what we already have with some of the third sector organisations in Hillingdon, but also looking at some more third sector organisations to do exactly that, do the preventative side of things. And I talked a little bit about the kind of 0 to 5 service, and also we've got the mental health in schools. We don't quite have all of the mental health in schools across all of the schools yet. We are really wanting to, and obviously how the money comes down from NHS England is it comes in different tranches, and we are having discussions at the moment, certainly in CNWL and in North West London, about how much do we want to be overspent to do that. Because we know that is something we want to do, but it's waiting for the kind of tranches of money to come through, because we believe that is one of the key things in terms of preventative measures.
Just a parting comment on that, if I may. I mean, thank you for that answer. Good luck with the schools. The ones that do the work, we tend not to have to worry about too much. It's those that we don't hear from and we don't engage with, and they're independent entities. I think helpfully the Ofsted regime these days does touch on children's mental health, so perhaps there's some hope for us in that regard. But thank you for your answer. Thank you.
Tony.
Thank you. Just back to the retreat again, because it's new. It's more of a comment really about, well, it's a question and a comment about being outcomes based. Is there follow-up work with the people using it to see whether there's preventing other services like homelessness and stuff like that? It would be good to see. Obviously, it's early days, and it'd be good to see in the April report, the outcomes-based evidence.
So, in terms of your question around follow-up, so patients, I think they're called guests. Thank you, Gary. They're called guests, actually, in the retreat, which is actually really, really important. They will be looked after by the home treatment team, and they will have a number of follow-up appointments after they leave the retreat. And I think your point around kind of the outcomes, so we're really trying to be patient-focused in terms of our outcomes. So we really want to hear from the guests around, like I said earlier, where would they have gone otherwise? But I think your point around kind of picking up some of the stuff around homelessness and maybe some other outcomes might be things that we need to look at in terms of our outcomes. That's really helpful.
Thank you, and I apologise for not calling them guests. So
No, that's
right.
fine. No, that's fine. I think
Yeah.
it's taking us a while to get used to calling them guests, not patients or service users.
But yeah, if you would take up I'm particularly interested in homelessness. And I've got another question just on the arch. See that you've reintroduced the drop-in assessments. How long have they been stopped, the drop-in assessments?
So they were particularly stopped over COVID, and they have started back. I'd have to come back to you on the exact date that they've started back this year.
Thank you.
Just on the retreat, actually, as there's been some interest in it, Nikki, would you be okay to circulate the paper to committee members that Gary mentioned from the Health and Wellbeing Board? Because there was some interesting case studies and an interesting discussion that I had about that, and yeah, definitely something we'll come back to in April. Okay, Vanessa, I think that's it for this item. So thank you very much for coming to see us, and you're free to leave if you wish to leave.
Thank you very much.
Okay, brilliant. Excellent. So we move on now to item 6, which is our adult social care update. This update is in 4 parts, and so we're going to take each part individually. Is that correct? Yes, Gary.
Chairman, shall I suggest that if I do A, B and D together, and then Sheikha can update the committee on the procurement item?
Yeah, definitely. So that's so Gary, if you start off doing the Care Act, adult social care funding reforms, adult social care contracts, and performance dashboard update, and then we'll take questions on that, and then Sheikha, if you do the public health procurement update. So yeah, excellent. So Gary, go for it.
Thank you, Chairman. Taking each of these in turn, I believe that Sandra Taylor actually just a report to a former committee meeting on this. Just to recap what the adult social care funding reforms were. These proposed to introduce a care cap of £86,000. So that once introduced would have meant that the maximum that people would have paid to meeting their eligible assessed social care needs would be £86,000 for the whole of their life. The second reform was an increase in the capital thresholds. Now currently the upper limit is 23,250. So anyone with income or capital of that value actually has to fund their own care. So essentially they're not entitled to financial assistance from the council. The third reform was around the fair cost of care. So that was seeking to address the differential in fees between those paid by local authorities and those paid by self-funders. Now the government has made a decision to pause the first 2 of those. So both the care cap and the change in capital thresholds will not now take effect until the 1st of October 2025. With the fair cost of care, the government is allowing us to keep the funding that it was going to make available to local authorities as part of these reforms, and is making some further money available, and is asking local authorities to move towards this. What we don't know is whether the money that was actually included nationally for the funding reforms is actually included within the new funding, or rather whether the value of the new funding actually includes that, and that is yet to be determined. And we also await information from government about allocations. So we're clear about the pausing of the care cap and the capital thresholds. There are still some outstanding questions really around the fair cost of care and the money that the local authorities are actually going to receive to implement that.
Gary, on that, so are we essentially saying that we don't actually really know how much this will cost when it comes in, because essentially it's been delayed for 2 years? because obviously there was a worry that this sort of, while the 87,000 cap is great for individuals as a local authority, you know, that cost has to be picked up somewhere, and social care is obviously already a big spend.
So that cost, so another cost that was going to be attributed to that was really the cost of additional staffing to undertake assessments. So that with that delay until October 2025, we're not expecting that there will be any cost pressures around increased assessments until what would be 24, 25, if I can get my financial years correct. So that would mean that we would need to start looking at that potentially towards the end of 2023, 2024, assuming that we actually get more information then about whether proposals for October 2025 are actually going to move forward.
Should I see if anybody else has got any questions on the Care Act, care funding reforms? I mean, essentially when we asked to have an update on this, it was before the delay, and so we were like, oh, this is coming up soon, it's going to be a big thing, and it's been delayed for 2 years, so in essence, I suppose it's less of a big thing right now. Obviously, it might become a big thing from mid-2023 onwards, but...
What I would say, Chairman, on the fair cost of care, will provide that, because that is a live issue. So we'll provide an update, a further update to the committee once the issues around funding have been clarified.
Does anybody have any questions on this at the moment? Yes. June, yeah. Can you put your mic on, June? Thanks.
Thank you. Gary, that 84, is it 84,000? 86,000. That is what someone will have within their possession before they can sell their property or before they go into a care home? Can you clarify that for me?
The change, Councillor Nelson, was basically that would be the maximum that they would actually have to pay towards meeting their care needs. So it's the contribution that they would actually have to make towards it. But as I say, that's been deferred until at least October 2025.
So just to clarify, if to get to that if to be able to afford that 86,000, they had to sell their home, they would have to still sell their home, because ultimately, as long as they're able to pay the 86,000, even if it involves selling assets, they would have to pay it. Obviously, house prices are generally a lot more expensive than that.
There are already deferred payment schemes in place which enable charges to be put on properties. So the intention really with the changes was that would not actually be required. So there would be similar arrangements under the changes. But as I say, I don't think that we should really sort of get too involved, with your permission, Chair, in what might happen or what might be. I think we really need to wait and see what government actually comes forward with in the future.
Okay, thanks, Gary. If you can move on to adult social care contracts, that'd be great.
Yes, I understand that the committee also asked to have more information about how the adult social care budget was spent. So what I've provided the committee with is a net breakdown showing also the percentages. So by net budget, what that means is the spend taking into consideration income and grants and charges. Happy to take any questions that the committee may have on that, Chairman, but I was actually going to make a suggestion as to whether the committee would actually like a further breakdown of the types of contracts and the spend against those, because it quite clearly we're spending nearly 70% of our budget on externally provided services.
I think that would be excellent. I mean, just for those who are watching and don't have this paper in front of them, I mean, essentially for 22-23, the sort of projected budget is basically 94.5 94 million, over 94 million pounds, and of that, almost 70% gets given to external providers, which obviously we make no comment on the good or the bad. But I mean, for me personally, I think what's really interesting is two factors really: how much we give to each area, broad area, obviously. So I don't know, stuff to do with prevention, stuff to do with care, or how you allocate the different parts of that care, but also as well, the type of providers who get the contracts, and if there's some providers who get quite a lot of the contracts, maybe who those are. I don't want you to name every single small provider necessarily. Also, I think what's of interest to me is which of those providers are social companies or volunteer groups, and which ones are not. So that's sort of the kind of information that I find interesting. But what I want to do is there any other sort of, when we get the breakdown, is there any other sort of information that committee members think would be useful to have in the breakdown? June?
Just wanting to know exactly what you said, Chair, in regards to who the providers are, how many of them are local or small businesses within the local health authority that is accessing that service, something that I'm interested in too as well, and how much of it is seconded out. That means that if the external provider, who do they subcontract it out to? Because that has got an impact too on the provision of the service that's being given to the client or the residents within the borough.
You can answer, or you can walk away.
Well, what I was going to suggest, Chairman, is that if perhaps we provided the committee with, say, the top 6 companies that we're working with, so that the top 6 that in terms of the amount of funding.
I mean, that is useful, but I think certainly at the same time we would certainly be interested in certainly not naming every sort of small company, but knowing how many small companies, because as well. So I mean, obviously the top 6 is useful, but definitely, we would be interested in, so let's say in this area, the top 3 or 4 providers who get this percentage X, but actually there are 15 providers who share in Y, for example, just so we get a flavour of the big little split. I mean, this will be an iterative process in a way. We'll get more information and have more questions, I assume. Anyway, Philip.
I'd welcome all that information. One thing that might be interesting, and I wouldn't want to create a lot of work in asking the question though, is whether these splits broadly reflect what we'd see in comparator authorities as well. Whether there's anything we can learn from that. So, but don't make a lot of work out of it. It's just an additional thought. That's all.
Yeah, Gary.
Yes, I can answer that straight away. It'll be pretty similar in most local authorities for adult social care. Chairman, what I'd suggest is that if I say put a proposal together for what might include in a report to come to the next committee to share with you, that you may want to consult with Councillor Nelson on.
Yeah, I mean, all by email.
Yep.
I mean, if, in a sense, obviously you've got a flavour of what we're sort of interested in, but I mean, I'm completely aware about what is possible as well, because as a committee, I don't want you to run after the moon. I want you to be able to produce what is possible. But if you could share that via email, then I'm sure we can. We can confer over email. But yes.
Some suggestions.
Yeah,
to what,
exactly.
Given the conversation to today, what the committee might actually find useful to know.
Exactly. So that'd be useful. Thank you. Okay. So and then you'd like to take number 4, which is the performance dashboard update.
Yes, this is a very quick one. This is something which is work in progress, which is due for completion in the new year, Chairman. So will be brought to the committee once that piece of work has concluded.
Does anybody have any questions on that? Or no? We look forward to seeing more about that. Thank you. Thanks, Gary. Okay, Shika, it's up to you now. Public health procurement update.
Thank you, Chair. I'm presenting this paper on behalf of Callie O'Neill, who regrettably can't be here today. So just to give you a bit of background, in April 22, this committee received a report setting out plans for future procurement of integrated public health grant-funded contracts. and Cabinet agreed an 18-month contract extension for all contracts in July, with agreement that we would review all contracts and make recommendations for procurement in 6 months, and then a 12-month tender timetable as applicable will be presented. And the process for this, as set out from that point, was that Kelly and procurement colleagues will have 2 weekly meetings with the contract leads, and this was for doing rapid needs assessments to look at what is the population needs, because needs always change, and in relation to when the contracts were agreed, how much the need has changed, and the service reviews, whether the services were delivering what they were set out to deliver, and to come to a reasoned decision about what options could be there for, and this aimed to be a consistent methodology across all of the public health integrated contracts. So Kelly is currently writing the final paper, setting out planned next steps, and to inform the annual procurement plan. The only challenge is the difference in contract value stated, I think, in both papers, because she's given the paper from April that's embedded in the report, and that's because there was a deep dive into the investments, and the real values were worked out, and that's where there is difference in the figures. I don't know if you want me to give a bit of background to the contract, so.
Should we just go into questions? I mean, I'm quite happy just to go into, because the papers were quite detailed, so I'm happy to go into questions. And then obviously, if there's anything you think we've missed after questions, then please do inform us. I've got a couple of questions, and I'll open out to the rest of the committee. But my first question is, if you look at page 12 of the report, it lists essentially bullet points what we spend on different things. So, for example, integrated sexual health services, 3.4 million, NHS health checks, 280,000, weight management, 25,000, 0 to 19 health child program, 4.9 million almost. Now, my big question is, how are those amounts decided? Because obviously there's massive variations. Some of them are a few 100,000, some of them are a few million. And for example, this is just off the top of my head, weight management seems to be a pretty big public health issue, spending £25,000, and it doesn't seem like a lot considering how big it is, literally, obviously, as well as financially. So really, I just wanted to know how we decide to spend the different amounts of money on those different public health matters.
Thank you, Chair. To the best of my knowledge, a number of those contracts were historic. So, when public health was in the NHS, the contracts were transferred, and those amounts, according to the services provided at that time, those were transferred. Services were reviewed on a continuous basis, but I think what hasn't happened is an overview of the whole of the public health budget, which is the process Kelly has undertaken, and for that many reasons, to look at what these contracts are achieving for us, whether the public health indicators are, we are doing justice to those.
Obviously, I appreciate, because Kelly couldn't be here, so obviously you're stepping in, and do really appreciate that. But I suppose I do want a more direct answer in terms of how we decide to spend that different money on different things, because ultimately, why do we spend 3.4 million on sexual health services? Why do we spend £25,000 on weight management services? Obviously, if this is almost inherited stuff, then obviously other people are making that decision. But is it a decision that we make as a local authority, or is it a decision that is driven by national health funding, for example, or is it a decision driven by the Integrated Care Board, or who is making those decisions? is basically what I want to know, because I think you could argue you could spend £1 million. I think if you want to spend £1 million on weight management, you could argue that's good. Obviously, money would have to come from somewhere else. So what I want to understand really is how do we make those decisions?
So, thank you, Chair. So there are some must-dos. So there are sexual health preventative services we have to provide, and that's a service where we have to ensure that population risk to the overall population is reduced. So we tackle, prevent, identify sexually transmitted infections. We provide contraception service. So as part of the Health and Social Care Act, we have certain mandatory requirements. So sexual health services, NHS health checks, health protection assurance, National Child Measurement Program, drugs and alcohol service. These are the areas where we must cover the must-dos, which are written in the Health and Social Care Act. And then there are non-mandatory services, some of which are also must-do, and those are, even though non-mandatory, but like weight management services, children's health services, so child health service, 0 to 19 service is part of our must-do. So some of these services are written in the legislation that local authority will continue to provide.
Okay, well, thanks for that. I mean, it's obviously very interesting for us, because the choices that we make and on evidence that we make and where we can and can't make it is, obviously one of the powerful tools potentially we have in the local area. My second question is related to paragraph 6 of the paper, which came to the predecessor committee, I think, in April, which is under public health planning for 22-23, and the first sort of paragraph says there are areas of each contract that need improvement, more focus on prevention and early intervention service and delivery, especially how we weigh service delivery to target individual groups that we know of high risk or vulnerable. We recognise that as we develop options behind our procurement plans, it is important that we more effectively build in robust evaluation methods that do not focus solely on activity and outputs, but measure outcomes and impacts of services for residents. Now, for me, this feels like a very big, important thing, and potentially a good thing, depending on how it's done. So, could you give us any more insight into what, because obviously this is from April, what's being done to make that a reality? Because obviously procurement, a lot of money is being spent, a lot of it is needed to be spent, but what is being done to make sure we spend and are able to it better and are able to evaluate the spend better?
So, Chair, as part of the process, Cali has been working with contract leads who have been doing needs assessments. So they are looking at how we prioritize certain population groups based on the need. So a needs assessment would go into demographic factors. It would go into epidemiology, which is the risk factors, how they are distributed in the population. But also, Cali is insisting that we go a step further and collect insights from our citizens as well as from professionals, so that we have a 360-degree view of what the need is actually like and what we need to prioritize. In addition to that, we are looking at public health outcomes framework, which has indicators that would contribute to the overall dual aim of which is outlined in the report. So under the grant, we are required to increase the healthy life expectancy and tackle inequalities. So there are indicators which would take a council towards those goals. So it's population insights, resident insights, plus needs assessment, plus monitoring of indicators, and that's the process that they've gone through.
So I think so Kelly O'Neill's our interim director of public health. For those who aren't aware, I mean, Nikki, is she coming to see us in February or something? Is it? Or I think is it January? Okay, excellent. So actually, very very soon. I know it doesn't seem soon. 2023 seems like a long way away. But I suppose for when she comes to see us in January, I think what would be really interesting is to see what that means in practice. You know, in terms of, or even if we're not there yet, in terms of the data and how we're translating it, in terms of what the data is we're going to be collecting and how we're going to be measuring that, because the words do sound great, and your explanation is I completely buy into, but really, you know, what is the physical embodiment of that is something that I'm really interested in. So I like good words, and I like to sort of go and see what do they really mean. So maybe if it's possible when Kelly comes to see us in January, a bit, some more explanation on that would be really appreciated. Okay, Philip.
Thank you very much. I actually chaired the April meeting, so it takes me back looking at this and hearing from you today, Sheikha. This has been a work in progress for some time, and I know that we've had to, I guess, as we've moved away from these legacy NHS contracts, which essentially they are, it's always struck me that it's a bit of an opportunity, really, for us to develop and shape services very much in our image as a local authority, and I suppose perhaps an opportunity to shape how services are delivered. So I suppose a quick question on the back of what you've already asked, Chairman, is the assessment that we've been undertaking around this, around need and the engagement with residents, does that include how people prefer to receive services? I'm aware, particularly when it comes to sexual health services, young people perhaps have a different view now about how that might best be delivered, and I just wondered if we are taking account of that in shaping these contractual provisions. Can you? I know we've got a report coming in January, but I'm just tempted to ask if you've got any thoughts on that, please, if you don't mind, Sheikha. Thank you.
Thank you, Councillor Cawthorne. Yes, of course. I mean, this is why the rapid needs assessment. So, for example, even during COVID, the way people access services has changed tremendously. So, there is online provision. There's a services young people can access via telephone. So, if they need a STI test kit, for example, there is SH24, so 24 hours you could access the STI testing service. So all of those things are being reviewed. And I just want to make one point, that as public health professionals, we, of all people, would like to have the opportunity to really recommend things that have not gone on right in Hillingdon. So this is we want it to be a very meaningful exercise. So in her limited time, credit to Kelly, she has really worked very hard and is trying to ensure that we have money for things, like children's dental health. We have more money for obesity. Tackling obesity. So she's also getting me to work on a whole systems program where we work on taking a systems approach to tackling obesity rather than individual interventions. So we would like, as public health professionals, to have to release some of the value where possible, obviously, within the contract.
Thank you for that, Sheikha, and you've certainly whetted my appetite for the January report, and I'm sure that's true of colleagues, but thank you very much. Look forward to seeing that.
June.
Thank you, sure. I just wanted some insight on page 23, the uptake of health check at borough level, and looking at the percentage here from 2018 to at present 2021-22, and the percentage of uptake on health check on the population that is presented here. It's got 80,000. In 2018-19, there were 77,949 in the population, and there was 63% uptake. In 2021-22, it's 81,561 with 49.2% uptake. And this is saying from data is collected on uptake by gender, age, and ethnicity. And there's concerns that there are on the screen groups which data confirm for the borough, men in all age group. How are they trying to involve the minority men into this? Because they got the eligibility is black and mixed race. How is that integrated into this? And how are they targeted for screening?
I'm sorry, Chair, I wouldn't have the exact details on how Becky Manuel, who's the program manager, is targeting specific groups, but we are going into areas of where there is greater deprivation, but also greater diversity in the borough, and that's the south of the borough. So awards south of A40. We know that there is concentration of populations from high need groups, and we are aiming to have more health checks. But also it's about targeting the GPs to encourage men to uptake the NHS health checks. We are also looking at, I think broadly there are plans to have. So there are plans to look at GP data and target the populations of general practitioners where the uptake isn't high, and also looking at digital provision. So there are a number of new things being introduced into new initiatives being introduced to encourage uptake by men. Recently there was a Men's Day celebration, and there was presence of NHS health checks there to encourage more men to come forward. We also target workplaces. So Hillingdon Bus Garage was targeted in the past. So we try different things, and I am aware that Kelly was collecting ideas from the team and wider, looking at other boroughs.
Hopefully we'll get an update to see whether the targets are being improvement on the targets, yeah?
Sure. Chair, one thing I can do is I can ask Becky Manuel to send an email to Nikki, maybe?
That would be brilliant that she could share with us. That would be fantastic. Thank you. Okay, great. Thank you. Rita.
Thank you, Chair. Thank you, Councillor Nelson. I think we're on the same wavelength of the question about the health check updates. I've got just two very quick questions. On page 17, we've got high risk and vulnerable groups and women attending for pregnancy terminations and repeated attendance. What are we doing with the individuals that are coming in for the repeated attendance? Page 17.
Rita, and because we discussed this briefly beforehand, and so elaborate on why you're asking, or is that going to be your follow-up question?
It might be the follow-up.
Okay, fair enough. Sorry, I've destroyed your advocacy technique, but yes. So yes. Sorry, go with that.
Sorry, could you repeat the question? So we've got women attending for pregnancy terminations and the repeated attendance for the same need. How are we tackling that issue for the same need? And whilst, I'll add the second question on then, so whilst the services, I take it free, how can we stop the repeat offenders coming in and using the service again? Could you do a levy on it or something, or, how can we prevent it from happening again and again? So I think women coming forward for repeat terminations tend to be younger women. So at the time of termination of pregnancy, it's important to have a good counselling session with the woman about contraception, also promotion of long-acting contraception. So all of these I mean, this is part of counselling women when they come for pregnancy. But we also, it's also an ongoing effort there's also an ongoing effort to educate women about pregnancy and the, unwanted pregnancy, teenage, there is a greater awareness raising effort among teenage pregnant women to get them back into education, get them back into work, so that they are motivated to improve their lives rather than getting repeated unwanted pregnancy, because we want to prevent unwanted pregnancies. Which I think, because it becomes a vicious circle, doesn't it? Because you come in and you're coming back again. It's sort of, for me, that being almost endless. But Rita and Steve, do you have any statistics on how many repeat attendances you have?
Yes, definitely. I mean, I don't have them to hand now, but we monitor those because ultimately our goal is to get women back into work and into education, because that prevents repeated unwanted pregnancies once they're motivated to improve their lives.
Lovely. Thank you. Sensitive subject, but still.
And if those could be shared with Nikki to share with us, those statistics, that would be very useful. Thanks.
Lovely. My final question is on page 27, where we're looking at smoking and quitters. My concern is around vaping. Is vaping replacing smoking? Because it seems to be more and more popular, especially with the younger generation. So where are we moving with that then?
So in Hillingdon, we, in many areas, vaping is being presented as an answer to smoking cessation. In Hillingdon, we encourage heavy smokers to we don't encourage vaping, but we give them the choice to quit through vaping. So in other boroughs, sometimes the smoking station service encourages, and in some boroughs they even provide a resource towards vaping. But in Hillingdon, we've chosen to, until it's supported by MHRA, which is a drugs regulation agency, because we don't have a product in the market which has been approved by MHRA. And until that happens, our strategy is to, if anybody wants to quit using vapes, that's their choice, and it's fine, but we encourage smokers to quit using the smoking cessation service and the 4-week support which the trained professionals provide in Hillingdon.
Thank you, Shika. So do you have any stats moving forward then of how many people have actually quitted using vaping, or have they just then stayed on to vaping and stopped the cigarettes but have enjoyed the vaping instead?
We don't monitor vaping and how many have quit using vaping, because we don't provide vaping. So those people who use vapes as a means to quit, they don't come and report to us, because we can't provide vaping. We don't monitor that, unfortunately. So we don't have that data, but nationally there is enough data available if you want to make use of it.
But do you monitor the ones that want to quit through vaping? So on your stop smoking, the quitters that say, okay, I will, because you said you advocate that, if you want to quit, you can use vaping as a method of quitting. So those that have said, yes, I want to quit, but I will use the vaping method, do you monitor those then?
I can ask the Commissioner if the service, because I don't commission the service, but I can ask the Commissioner if they
would be interesting.
Are monitoring this part. Yeah.
Oh, Tony.
Thank you. Just looking back on page 18 and 19 on the substance misuse, drug and alcohol service contracts, just disproportionate number of male and female users of the drugs. I've read the report on it, and I just wonder if we're reaching out, how we're reaching out amongst females to get more to come forward, because I'm sure there's quite a few more female drug and alcohol abusers out in the community. And it just seems the numbers, we seem to be getting many more males coming forward than females, and I wonder what we're doing to encourage more females to attend the services.
Again, it remains an ongoing challenge. So it's through, I think, where you notice other risk-taking risky behaviours, that's where we target females. For example, those who come into contact with services through trafficking, the women who have been in trouble with the law, so through criminal justice. So that, to the best of my knowledge, that's how. But I'm sure we can give a detailed answer to that, because these services are, commissioned and then provided by health providers. So I can ask the commissioner that question, how, because I don't have the answers about how detailed.
Yeah, thank you. I was just worried it's so disproportionate across all levels, and I'm sure there's a bigger usage out there than
yes,
equal to males, and definitely, I would say.
Well, I think needs assessment. So once we've done the needs assessment, instead of me speculating any answers, I think once we've done the needs assessment, it will be clearer, because they will compare the data, national data, with the local data. So in some communities, for example, even if we take smoking, where I'm aware that levels of smoking vary across the communities. In Bangladeshi community, for example, a greater number of men smoke, and women don't smoke. That's the case in Bangladeshi community and many Asian communities. So the rates vary across different communities. So I think once a needs assessment is done, we will know what is the real need specific to Hillingdon's population, and you will get a much more intelligent answer rather than me speculating here.
Yeah, June, yeah. Go for it. Sorry, Tony, if you finished.
Yes, thank you, Chair.
Great, June.
Chair, on the same page 19, just a quick observation based on the National Drug Treatment Monitoring Services. It says the data Hillingdon has the 12th highest prevalence of opiate users and 17% highest rate of cocaine and crack in London between the age of 19 and 59, which account for 91% of the service users accessing the service. So the table below that, it shows that drug use by service users accessing the service, and then it states what they are. You got 410 male and 125 female. With crack without opiate user, you got 10 males and 0 females, a star. Is that because that information has not been collated? And the numbers,
Yeah.
How is the numbers attended? Are they not coming forward? Is this due to people in prison, or due to people who is homeless, or due to people who is not coming forward either via the service users for drug usage or mental health usage, that sort of thing?
I'm certain that the numbers represented here don't represent the complete picture. So it's always underrepresentation, because we are on an ongoing basis. It's a struggle, challenge to identify people and treat them. The asterisk is often when numbers are below 5, so we don't. Yeah, so it's probably that. So our data team does that when the numbers, so that, you know, in small number of individuals are not.
Yeah, no, it actually says data has been suppressed due to low numbers.
Yes. Okay. Yeah.
So, are we... Excellent. Okay, well, we're done on that agenda item. And obviously, there was a lot in that agenda item that we're going to be coming back to, so very interesting. So, thank you. Shiki, you're welcome to stay, but you're also welcome to go. Up to you.
Thank you very much. I will leave.
Yep.
That's okay. I just want to make one last
yes, of
point.
course, go for
that,
it. Yes.
You know, these are massive contracts, and while I don't have the detail of you know, every service and what they're planning to do, and even if I do give the detail, that is going to change. So I know, based on this data, the drug use is now different. I know that much. So I think what we need to do is wait for the needs assessments and Callie's overview of everything, and I hope in future you will get answers to your questions. But in the interim, what I'll do is I'll take the queries back and get commissioners to say something. Yeah.
Yeah, no, I know the overview that's being done is comprehensive and does sound very interesting, and I've asked Kelly to talk about that to this committee, so hopefully she'll do that in January. Excellent. Okay, well, thank you very much. And you may have the rest of your evening back. Unfortunately, there's no football for us to watch this evening, which is, I don't know what, I won't say that's a coincidence why I set the date of the meeting for today. But anyway, right, so we're on to agenda item 7, which is the 2022-23 Better Care Fund Section 75 agreement. So, Gary, that's you again, and Sean, are you going to be joining us on this one, or? Yeah, as well. So, okay, we'll take the agenda items you wish.
Start off, Chairman, by introducing Sean.
Yeah, no, that'd be great.
To the committee. Actually, Sean, do you want to introduce yourself if you'll get the Chairman?
Can do, thank you, sir. My name's Sean Bidewell. I work for the North West London ICB. I'm based in the Hillingdon Borough. I'm the interim joint borough director, but my substantive role is AD for integration and delivery, and I've been working with Gary.
You work with Richard?
Yes.
Excellent.
So I'm supporting him as the counterpart.
Fantastic, because Richard comes to us a lot. We know Richard very well. So, but you're very welcome, Sean, to be here.
Chairman, the committee actually asked to see the BCF Section 75 before it went to Cabinet, and it's due to go to Cabinet on the 15th of December. What you see that I've done is tried to explain a bit about what the Better Care Fund is, because I thought the committee might find that useful rather than just sort of receiving the raw Section 75 agreement.
I found it very interesting. Thank you. So.
What I'll do is just sort of, if you're happy, Chairman, I'll just say a few words about. So I mean, basically, the Better Care Fund is an initiative that's been around since 2014-15. Introduced by government to try and bridge the different legal systems that exist for health and social care. The committee may well be puzzled as to why it's receiving the 22-23 agreement in December. This is unfortunately due to a nationally set timetable, and we have consistently faced an issue through the lifetime of the Better Care Fund with planning requirements being published late, which often means that this tends to happen. So it's completely out of local control. So what the agreement does, what the Better Care Fund does is sort of set out within a plan meeting national requirements, how the council and health partners will actually work together to deliver national and local priorities. In Hillingdon, we see it very much as the mechanism for delivering those aspects of the joint health and wellbeing strategy that require integration between health and social care, or closer working between health and the local authority for delivery. the agreement itself, as you can see, is very detailed. It sets out those aspects where we're looking at a delegation of functions, so where there are health functions that are being delegated to the local authority and vice versa, and also setting out the financial arrangements. So that's where health money is coming to usually to the local authority to usually to deliver services on behalf of health and to meet jointly agreed objectives. The agreement, you'll see, actually sets out risk share arrangements. It also sets out in some detail the operation of certain schemes and clarifies arrangements around particular aspects of funding. So, say for example, in terms of Section 117 mental health aftercare arrangements. Shall I pause there, Chairman, and then what I can say, come back to later, is that because there have been some developments in recent weeks that I can talk a bit about further, and it might be worth actually just sort of talking about what happens next. But if we pause there, Chairman, for any questions that the committee may have.
No, that'd be great. I'm going to ask a couple of questions. I mean, as everyone on the committee is discovering, sort of how healthcare and the broadest public health is organised in a local level is mesmerising, and so always a learning experience. And for me, actually, this is really interesting as a learning experience about how the Better Care Fund operates and what it should be doing. So, I really appreciate this paper and seeing this before it goes to Cabinet. I've got two questions. The first one is to do with basically on page 37, paragraph 24. It says, as of for the last 2 years, the council is intending to use the funding to support the local care market. And then I noticed on page 39 on the scheme 5, there's implementing a coordinated approach to support the sustainability of the regulated care market. I just wondered, what does that mean in practice? Are we interested in local? Are we interested in funding local or supporting local, or what do those sort of statements mean? How does that work?
The intention, there, Chairman, is to support the sustainability of local providers, so that we are actually able to meet the care needs of our residents locally. So the council actually has a duty to develop and support the market under the Care Act, which is one of the reasons why we do have delegations through the Better Care Fund to commission services on behalf of the ICB to secure local provision within the care market.
Do you have a feel for how the local care market is?
That's a big question.
It was a small question with a big answer, hopefully.
The local, I think the care market nationally is struggling, and there are aspects within the Hillingdon care market that actually reflects the national position. So one of the things that we're finding is that we do have some struggling providers within both the care home and the dom care markets.
So what does supporting them look like, or supporting the local care market look like?
Supporting them, the local care market is with funding. So we've channeled funding that we've actually received from central government. There is also support going in terms of actually training both within the care home setting, but also dom care providers in addressing particular needs. And I think Falls is actually a very good example, and with wound care. There's another good example, I think, of particularly good examples with the care home market is the care home support service, which is a sort of collaboration of primary care and CNWL, who actually have a team of care home matrons who are contacting the older people's care homes on a daily basis, and the care homes for people with learning disabilities and mental health needs on a weekly basis, to provide support. And part of that is actually about seeking to avoid hospital attendances and admissions, and supporting the staff to deal with issues that may arise before they turn into crises. And the council's quality assurance team is actually going into care homes and also supporting the home care providers. So those two areas also represent our biggest areas of spend. So trying to support their staff actually helps to sustain the quality of care for residents as well.
And that's very important. That's interesting. Thank you. My second question is probably less to do with the detail of this report in a sense, but just a personal question in terms of something that I've heard but I don't really understand. And as it's in the report, I'm going to take advantage of that and ask what it means. What are personal health budgets and how do they work? I mean, on page 89 we have this diagram which completely confused and scared me, to do with personal health budgets, which I didn't understand and looked completely complicated and crazy. But I've heard it discussing, but I haven't really got to grips with what it is. So if you could explain to me what personal health budgets are and how they work in practice, I'd really appreciate that.
Well, a personal health budget is quite similar to a social care personal budget. So it's an identification of a sum of money to meet health need, and then that can be met in a number of ways, either through a managed budget, or a commissioned service, so directly commissioned in this instance by the health service, or by the local authority on behalf of the health service, which happens particularly with people with learning disabilities, for example, or it can be provided as a direct payment. So it's basically a sum of money is actually provided, can be in the form of a prepaid card, or it can be some money which is paid directly into an account or directly to a provider, for a service which the individual has actually chosen. So it helps to ensure that service provision is more personalised, gives more choice. Something that we're actually looking at the moment is personal health budgets to support hospital discharge. So it will cover the sort of which seem quite small things by themselves, but actually have quite an impact. So being able to just trying to think of an example now that I've actually said that. So it would help to cover, say, for we're looking at a particular instance where somebody may actually have difficulties meeting fuel costs. So I mean, there's looking at a grant of up to £200, which it deals with an immediate problem and actually expedites the discharge. For the most of the personal health budgets that are made as direct payments, as you can see within the document, that's something that we manage, the local authority manages on behalf of the ICB, because the process is more or less exactly the same as our own direct payment service.
So individuals get the ability to spend money themselves on different outcomes to help their health, essentially. So we're sort of empowering them, which hopefully will allow them to make those choices which get what we want. Is that?
Yes, it's more enabling, and it can be paid to the individual in different ways. As I say, one form is through a prepaid card.
Thanks. That was key. I was just curious about that. Right. Do we have any other questions, Philip?
Couple of questions. Gary, it made me chuckle when you talked about the time lag with the reporting, because some things don't change, do they? Names and faces change, but certain things don't change in terms of how it's reported.
Names and faces don't always change, do they?
Well, no, indeed, in some respects they don't. No, quite. I'm just interested, having been involved in this for some time, as you know, Gary, in terms of how the whole BCF process, the relationships between providers and commissioners in the context of the ICP has developed and matured in more recent times. Certainly my involvement ended just prior to COVID, which was a massive shock to the system, of course. But I'm just interested really in how some of that joint work, some of that risk sharing, that joint commissioning is developing, maturing, I suppose, or not, as the case may be. And obviously now we've moved away from a Hillingdon CCG towards a regional approach with NHS North West London. What difference that's made at all to the process? Thank you.
So one of the things, locally, I think our ambition with the BCF and to a certain extent your question, Councillor Cawthorne, actually addresses or touches on the point I was going to make about what next. So going back a bit, local ambition was actually seeking to bring more into the BCF. So particularly what we've discussed is more around children and on adult mental health, so that the BCF actually becomes our place-based health and care budget. So and the Section 75 becomes the legal framework for that. So that's what we've discussed, and that's actually pretty much in line with what was in the Health and Social Care Integration White Paper that was published in February. What's held it back is the changes in two things. There's the changes in legislation which actually created the ICB, and also the delay in publication of the planning requirements. That was the planning requirements for the 22-23 BCF, but as you alluded to, Councillor Cawthorne, it was the same in 21-22. So those timescales didn't actually work for us to be able to move that forward. For 22-23, as I say, the ICB had just actually formed, so that actually held us back as well. We're actually looking now. We're having the discussions again about seeing if we can actually move that forward for the next iteration of the BCF, and what we understand the intentions are with that is that it will be a 2-year plan from April 2023 to 2025, and the hope is that the requirements will be published in Q4. We remain hopeful. So the intention would hopefully be again to expand the scope and potentially bring other health partners into the Section 75 agreement, to give greater flexibility in our responsiveness to the changing needs of the local health and care system.
We finished, Gary?
Yes, sorry.
Okay. Thank you for that. I did have one further question, and it's around discharge to assess. That's not happening now, I gather, from the report, from reading it right. Is there something that's come in its place, has it? Or you touched on personal budgets to support discharge, so is that part of a package of measures that are there to support with this?
What happened was that the decision in 21-22, following on from arrangements that were introduced during the earlier part of the pandemic, funding was made available for the first four weeks for new placements and for new packages of care, so new home care packages. That stopped this financial year, which meant that we're in a position to have to start undertaking financial assessments again in hospital, which has introduced a delay. What we're still seeking to do is working with partners, as I say, is to put in place services that enable us to get people out of hospital as soon as possible. What has just happened, which was Chairman, was the point I was actually going to make about one of the changes, is that on the 18th of November, we got the grant conditions published for the hospital discharge fund, which has actually made quite a lot of money available. So it's not it's nearly a bit. I think it's just over £1.9 million for the system. 867,000 of that has actually come directly to the council. This is, as it sort of says in the title, all about supporting discharge. We have to submit a plan for using that money by the 16th of December, and it all has to be spent by the end of the financial year. And that will be included, has to be included within the BCF, and will require a change to the Section 75. So Cabinet will be asked to agree delegation arrangements.
June.
Sorry, Gary. Following on from that, there's I'm on page 55 here of the pools funds. Who controls the pools funds and how does it operate? Would that, out of the pools funds, will that help support patients in hospital who we would call bed blocking, be able to come back out into the community and live their life either in the nursing home or back into their own homes?
The council hosts the pool fund. So basically, the pool fund is about money going into it. The way we operate it is like a joint bank account. In terms of actually assisting people to get out of hospital, what you'll see within this document are a range of services that are funded to actually assist that very process to get people out as soon as possible.
So that's why it is set up the way it's set up, okay? And that is accessible between the health authority and the hospital, the NHS.
Yeah. So what's in here? The pooled fund actually supports the services that are that some of them are actually delivered by health providers like CNWL. But some of them are provided by private providers like care homes or home care companies. So again, just to reiterate that a larger proportion of our spend is actually on the care home market and on home care. And access to that is via the health authority, or is it a combination between the health authority or the homes or the commissioners who provide the service? Yeah. For discharge purposes, it would go through the integrated discharge team within the hospital. So that's a combination of health partners. So that would be Hillingdon Hospital, CNWL, but it will also include the hospital social work team. So it's a collaboration between partners, multi-agency. So it's not just one partner is working on it.
The reason I'm asking that question also is to get a clarity on patients who are stuck in hospital and doesn't need to be in hospital hospital, but there is no availability for either the service providing in their homes or the community. So therefore, they're not being able to discharge from hospital. So if that fund is available, the NHS is, and the local authority, if that comes to the surface, which it does, under the daily discharge plan that goes on, does that come to light? Because if that comes to light, then surely that provision should be able to move patients on.
We don't, unlike a lot of authorities, we don't have any delays with packages of care. So a lot of authorities have issues with their home care agencies not having a capacity to take people on. What we have in place is a bridging care service that enables people to leave home. They get support by the bridging care service for up to 7 days. That service will then, working with social care, determine whether someone goes into reablement for up to 6 weeks, so depending on whether they've got reablement potential, or actually goes into a home care agency for ongoing care. Care homes are a bit more problematic because we have very high levels of occupancy within the borough. So we've got something like about 93% occupancy within the borough. However, what we've done is, and are intending to do to cover the winter period, is actually block book some beds to enable people to step down. Now for those people who again have rehabilitation needs, we have the Hawthorne Intermediate Care Unit, which has got 22 beds. So that provides sort of intensive rehabilitation to people who actually require rehabilitation in a bed-based service.
Great. So I think we're done with our questions. Gary, was there anything else you wanted to mention?
No, Chairman.
Covered it all. Brilliant. Fantastic. And Sean, you've sat here and you've not spoken, which is okay. You don't need to speak, but was there anything you wanted to mention or?
No, I mean, Gary's got a lot more knowledge on a lot of this stuff. I feel I need to step in to support, but I think he's answered everything really well. So we're involved in the integrated discharge as well. So we're involved in the calls on there twice daily to support the patients that can leave hospital to move them to the right place. But it's the services that Gary's described quite well. Thank you.
Brilliant. Well, thank you both for being here, and I know, Gary, you've had a marathon session with us, so thank you. It's always appreciated. So you're both free to leave while we discuss our work programme, so thank you. Excellent. So we're on to our work programme. A couple of thoughts. Firstly, Nikki sent round an email a few weeks ago about a review into the orthopaedic inpatient surgery in northwest London, which is currently at Mount Vernon, and talking essentially about moving it from Mount Vernon to Central Middlesex Hospital. I think is it Central Middlesex or Middle? Anyway, I think it's the one in England. Anyway, but essentially, I think, and the consultation closes. Well, it closes just before our meeting, but I think it would be useful to have somebody coming to talk to us about that, because one of the things that certainly seems to be an issue to me in the report is their justification for moving it to where they've moved it to is because the average journey time is only X. Well, the truth is, I think from Hillingdon getting to there by public transport is a lot more complicated, and also people who need orthopaedic care, mobility might be an issue. So I think that's something I'd like to drill down into. The second aspect of it, actually, as well, which is actually useful in a way that the cancer centre moved from Mount Vernon is going to be moved to that that meeting as well, is that I have an underlying concern about what's happening with Mount Vernon. Things seem to be moving away from it, and about 9 months ago I did ask Hillingdon Hospital what's going on with it, and they said, well, nothing, it's still great, we're going to use it, especially when we're doing when we do the hospital rebuild, it would be a good place to go. But I think, you know, initial questions about why you're moving away from Mount Vernon is useful to get into. So if the committee's okay with it, can we ask them to come and present to us on that? Is everyone happy with that? Yeah, Tony?
Yeah, I'm more than happy, because I asked, I got the service mixed up, because I asked the chief executive at the last meeting about physio services moving, and it's obviously not the physio service, it's this one, so I will be interested, yes.
Also, I've been asked if we're happy to move the sorry, just move down here nicely. The implementation recommendations from the review about making the council more autism friendly to April, because this will combine it with the consultation we're doing on the draft autism strategy, which obviously was influenced by the review. So it makes sense for it to be that way. Obviously, it's neat in a way that we're adding one extra item to our meeting in January and removing another. So are we happy with that? Yeah, I think it makes sense. If that's the right time to have it, then that makes sense. Excellent. Is there anything else on the work programme?
Well, there's lots of other things in the work programme.
No, but anything else like different from what's written down? No, excellent. Okay, well if that's yes, sorry. Oh, sorry, Philip.
Should I say our March meeting looks a bit light, or am I not reading it correctly?
It's not going to be light.
Okay.
I mean, we will never have a light meeting. Well, first of all, the cabinet member. No, is she coming in April?
Yes, April.
Okay, fair enough. We've got the health updates in March, wasn't it?
We've got health updates in April.
Okay, fair enough. So one of the things that we're going to be doing in January, obviously, is confirming our reports, and essentially the space we have now will be filled with investigations for our report into CAMS, and so yeah. I mean, it'd be amazing if we had a meeting which had nothing on and it went very quick.
Never going to happen.
We deserve it if it happens, but it's not going to happen. Excellent. Okay, if we're done now, I'd like to wish everyone happy Christmas and look forward to working with everyone in the new year. So, thank you.
Thank you.